I want to welcome a very, very good friend and colleague, Andy Cutler. Andy is where I'd like to be in the Sunshine State right now in Florida, where Andy lives. Andy has links to Toronto. In fact, we were going to be having our program in Toronto in person. I was looking forward to having Andy back home, so to speak. Andy and I have known each other for a long time, a couple of decades. Andy, I don't want to date us, unfortunately, but a couple of decades already. Andy is a psychiatrist, a true scholar, and psychopharmacologist. And Andy has, for many years, led more clinical trials in psychiatry across depression, bipolar disorder, ADHD, and I'm sure I'm not covering them all, than anyone else I know in America. And is now the medical director of Neuroscience Education Institute, which is the largest education provider in America. And I was so delighted Andy was available to speak to this topic. Andy's great to have you. You're going to speak to ADHD. The floor is yours.
Okay, thank you, Roger. It's a pleasure to be here with my good friend Roger and my new friend Josh. And I want to thank you guys for setting me up so well for this particular talk, which is a tongue-in-cheek, of course, myth or medical, it's all in your head. And where this comes from is a professor of mine once taught me that when patients ask him, is this all in my head? He would say, of course it's in your head. Your brain is in your head. So that's what we're going to talk about. Now, relevant to the interdimensional discussion that we were having today and the idea to integrate our three talks, ADHD really does cross over with cognitive problems, obesity, and depression, especially when we talk about motivational and hedonic deficits. So I hope to give you a flavor of that as we go along. First of all, if I can get this to work, here we go. So of course, learning can be fun. And so you'll see I have a couple of fun slides as we go along, and this is one of them. This actually comes from a t-shirt I got when we completed a clinical trial on ADHD with a particular company. They gave us these t-shirts that had this logo. So I'm certainly a big rock fan and an AC/DC fan. And actually the lead singer of AC/DC, Brian Johnson, lives very close to me here in Sarasota, Florida. That's a fun little tidbit. So here's what we're dealing with. Here's how the public sees ADHD and drug companies. Here's how it works. First, we discover the drug, then we identify the market, and then we invent the disease. So sadly, this is part of the myth of ADHD. A lot of people don't believe in it. They think it is sort of made up and that it's a way for people to medicate kids or for adults to get illegal abusable stimulants. I'm a big fan of history. I want to just take you quickly through some of the historical moments here that, especially when we're talking about adult ADHD, I don't know about you in the audience, but certainly probably Roger will share this. When Roger and I trained, I was trained that ADHD was a childhood disorder and that you outgrew it, which of course we now know is just not true. Neurobiologically, that makes no sense. There's no other genetic neurobiologic wiring problem in the brain that you outgrow. You may outgrow the criteria, but not the functional, the neurobiological and functional impairments. So ADHD, believe it or not, was first mentioned back, we think, in 1798 by Crichton, a disease of attention causing an unnatural degree of mental restlessness. And that really still fits very well today, particularly for adults, where the external overt hyperactivity goes more internal and you get that internal sense of restlessness and impatience. In 1902, George Still, in a very famous series of lectures at the Royal College of Physicians in England, talked about, this was the Victorian era, so he talked about a defect of moral consciousness, but the key thing was it can't be accounted for solely by environment. So inattention and disruptive behaviors have an organic cause versus bad parenting, and this was a radical concept in the Victorian era. Then we had of course, something we're referring back to very commonly now with our current pandemic, the viral encephalitis, influenza encephalitis epidemic, or pandemic, I should say, in 1917-18 and then again in 1919-20, where it was noticed that people who had viral encephalitis had the symptoms that looked like ADHD with inattention and hyperactivity, poor impulse control, and eventually the terminology that was given, especially to these kids, sadly, was minimal brain dysfunction, as if there's something wrong with their brains. Now, in 1937, Benzedrine, which is an amphetamine, was shown to be effective for what was called minimal brain dysfunction in kids. Interestingly, it was also approved as the first antidepressant back then, and there's some really interesting articles, if you want to laugh, that were published by the American Medical Association recommending the use of amphetamines. I don't think you'd ever see that today. And then in 1957, methylphenidate was approved also for this condition. Methylphenidate had some very interesting approvals, including chronic fatigue and mild depression, which obviously can be seen also with ADHD, as we've talked about this overlap. In 1967, when DSM-2 came out, this terminology was revised to hyperkinetic reaction of childhood, which unfortunately refocused the condition onto hyperactivity and away from the attendant problems of inattention and also impulse control. And so for a long time, that was kind of the concept here. And that led to an interesting change in the medications that I'll talk about in a minute. But in the world of adult ADHD, the seminal moment was in 1976 when Paul Wender at the University of Utah published the Utah criteria, also sometimes called the Wender criteria for adult ADHD. And he included the cardinal symptoms that we all know of inattention and hyperactivity. But look at what else. Mood lability was considered one of the cardinal symptoms of ADHD in adults. Irritability and hot temper, impaired stress tolerance, and disorganization and impulsivity. And really, as a clinician who sees a lot of patients, I've been treating patients with ADHD for almost 20 years, boy, does that fit. That really fits. So that was a really good clinician making accurate observations. DSM-3 changed the terminology to ADD, and which is the term that's still commonly used in the common parlance today, attention deficit disorder, but they conceptualized it as inattention and hyperactivity only. They took out the emotional responsiveness, the irritability, the hot temper. The low frustration, tolerance, temper outbursts, and stubbornness was then moved into the associated features of ADHD. And part of this was because psychiatry was trying very hard to cast off the shackles, if you will, of psychoanalysis, and they wanted to be seen as very hardcore biologic, and they felt that inattention and hyperactivity could be observed and measured, whereas these other things were soft and couldn't be as well measured. And sadly, that's a bias that we live with today, even in DSM-5. 1987 DSM-3R changed this to the punctually challenged, the grammatically challenged, if you will, nomenclature of attention-deficit/hyperactivity disorder, ADHD, which is the professional term today. ADD is relegated to now kind of common speech for layman's terms, but can be associated with the inattentive type of ADHD. In 1995, Paul Wender wrote the first book about ADHD in adults, called Attention ADHD in Adults, basically. And in 1997, someone that we all know in the ADHD world, Russell Barkley, who is really one of the most crystal clear thinkers and one of the greatest writers about ADHD you'll ever find. And he talked about ADHD symptoms and behaviors across the lifespan, including not only inattention and hyperactivity, but again, impulsivity, anger, defiance, resentfulness, and conceptualize this as impaired impulse control as one of the cardinal features. Self-regulation was part of his conceptualization. Now, there are some myths, of course, that ADHD, attention deficit hyperactivity disorder, I like to say all four of those words are wrong. It's inefficient regulation of attention. It's not a deficit of attention. Hyperactivity is not necessary to make the diagnosis. And it's not a disorder. It's a different way of information processing. And in some settings, it's actually an advantage. There are some tasks and situations where the ADHD brain functions better than the non-ADHD brain. It's the most common neurodevelopmental behavioral disorder, about 10% worldwide. I've attended some international conferences, and I'm always amazed how it just clusters right around 8 to 12%. It's not, quote, good or bad. It's just different information processing or wiring, the circuitry, if you will. There was a book written at one time called You Mean I'm Not Lazy, Stupid, or Crazy? And of course, you're not. There's a myth that you can't have ADHD if you're successful or a professional. And that's certainly not true. I've treated doctors, professors, lawyers, all types of people. And I love the one, quote, I got tested and they said I don't have ADHD. There's no test for ADHD. There's no neuroimaging procedure, sadly. It's still a clinical diagnosis. Prevalence, conservatively, 6 to 8% of children and adolescents, 4 to 6% of adults, some studies as high as 16%. In my clinical experience, and again, reviewing a lot of data and literature, it's probably around 8 to 10%. Again, for all ages. Now, it's not diagnosed the same in adults, and again, they may outgrow the criteria, but not the neurobiology or the functional impairments or the impairment, the distress. The prevalence is underestimated. There's comorbidities and intelligence that can help compensate. Girls with inattentive symptoms are under-recognized. It's difficult to diagnose in adolescence where you have a lot of emotionality anyway. I have 2 adolescent sons who are addicted to video games, which makes it tough to get them to do anything. High persistence into adulthood. You might outgrow the diagnostic criteria, as I mentioned, but not the impairment. And what it causes problems with is social function, intimate relationships, occupational achievement, driving, and so on. The importance of a careful evaluation. The doctor's saying to the patient, this is a second opinion. At first, I thought you had something else. And this is certainly germane to our discussions today because ADHD is frequently misdiagnosed, just like bipolar disorder is frequently misdiagnosed as unipolar depression. Because of the significant comorbidities, ADHD is frequently in adults misdiagnosed as depression and often treatment-resistant depression because the ADHD brain doesn't respond as well to serotonergic interventions alone, such as SSRIs, and also anxiety. So those are usually the tip of the iceberg. The patients who are adults will usually present with the depression or the anxiety. The kind of depression is very relevant to what Roger was talking about. It's very often an anhedonic, amotivational kind of depression that they have. It's beyond the scope of the time that we have to go into the full DSM criteria, so I'm not listing all of the symptomatic criteria. Suffice to say, there are 2 clusters of symptoms, inattention and hyperactivity/impulsivity. And there are 2 main changes I want to highlight here that have to do with adults in DSM-5. The first is that now for patients 17 and older, the threshold symptomatic criteria dropped from 6 out of 9 to only 5 out of 9 of either or both of those 2 clusters. The other one is that the onset of symptoms was moved from before the age of 7 up to the age of 12, which is really helpful when you're interviewing adults. Sometimes it's very hard for them to remember what they were like when they were 6 or 7 years old. The way it's divided in DSM is into presentations, which we used to call types. So we have the predominantly inattentive presentation, which is either 5 or 6 of the 9 inattentive symptoms, but not necessarily of the hyperactive impulsive symptoms. We have predominantly hyperactive impulsive presentation, which is vanishingly rare in my experience. It's very hard to have hyperactivity without having inattention, I find, but that's the hyperactive impulsive cluster only. And then combined, which is the most common type, which would be 5 or 6 of 9 from both clusters, depending on your age group. And then there's other, specified or unspecified. You can specify why you're calling it other, or it could be unspecified. We used to call this NOS, not otherwise specified. There are structured diagnostic interviews that can be used, the ACDS, the CADED, which is the Conners Adult ADHD Rating Scale, the MINI, which is David Sheehan's creation, and the CASADS, which is actually for children only. There are multiple rating scales, just like we have scales where we can measure depressive symptoms and anxiety symptoms. The ADHD RS5, which is the ADHD rating scale tied to DSM-5, that's rating the 18 symptoms out of DSM on a scale from 0 to 3, and then you add up and get the total score. ADHD RS5 has some prompts in there that are more specific to adults because the original DSM criteria were really written for hyperactive boys, if you will. There's the ACERS, the adult, it's the ADHD Investigator Symptom Rating Scale. The CARS, which is an adult scale, Conners again. The RADS, which is the Wender-Reimer Adult ADHD Rating Scale. There's the Brown Scale. And then there's a self-report scale called the ASRS, which is very helpful. ADHD is a highly genetic disorder. This is another myth or another misunderstanding. And as a matter of fact, it's higher than some other things that we think of as very genetic. It's more genetically loaded than breast cancer and asthma. It's almost as genetically loaded as schizophrenia, and it approaches height. So the mean is, there's some studies now that are 0.6 to 0.8 contribution. Also, family studies, and this is very important as a clinician, that if you identify a proband with ADHD, you need to be aware of the possibility of others in their family orbit. The incidence of ADHD in first-degree relatives is 5 times higher than in control families. The subtype of ADHD of an affected parent does not necessarily predict the subtype of other affected family members. So you can have one patient who has combined type and another one who's a first-degree relative with the inattentive presentation. I love this slide, one of my favorite slides of all time. Excuse me, doc, my attention wandered. What type of deficit disorder did you say I had? I want to make a t-shirt of that one. That is wonderful. So Now, talking about neurobiology, an emerging view of the pathophysiology of ADHD, it's a dysfunction of fronto-subcortical networks, top down and bottom up. But particularly, there are problems we know in the anatomy and functioning of the prefrontal cortex and the connections with subcortical networks. We know there's dysregulation of several neurotransmitter systems. We certainly know this from the fact that all of our currently approved effective ADHD medications are working on dopamine and norepinephrine. But we now also are recognizing the role of serotonin as well, and there's one medication in development I'll talk about in a minute that has some serotonergic activity in addition to norepinephrine and dopamine. And maybe other neurotransmitters as well, histamine and acetylcholine, which are very involved with cognition. Current effective medications, as I mentioned, work on dopamine and norepinephrine. There's high genetic association, but unfortunately not a really specific mapping to one or two genes. There's a number of genes involved, each with a small effect. You can see dopamine genes here, you can see serotonin genes. SNAP25 has to do with norepinephrine. There's also connectivity genes and synaptogenesis genes that are involved as well. And there's significant environmental influences as well, as we know. The prefrontal cortex, its job is to process incoming information to determine an appropriate response. How important is that for survival and adaptation? It orchestrates your thoughts and actions in accordance with internal goals, responsible for executive function, which is impaired in the majority of patients with ADHD, and it regulates the circuits through top-down and bottom-up processing, as I mentioned. The PFC is, really we think of the PFC as three different regions that regulate three different circuits, and these circuits are highly germane to ADHD. The dorsolateral prefrontal cortex regulates circuits that have to do with attention, and impairment, of course, may lead to inattention and distractibility. The inferior prefrontal cortex has to do with behavior and hyperactivity, if you will, impulsivity, although the orbital frontal cortex is also very involved with impulsivity. And then the ventral medial prefrontal cortex. So biologically, emotional regulation is part of the pathology of ADHD. You have problems in all three of these circuits, and yet again, our two cardinal clusters of symptoms are only inattention and hyperactivity, and not the emotional dysregulation. And sadly, this can lead to socially inappropriate behaviors and a lot of difficulty with social functioning. Executive function, Roger talked a little about this: analyze, process, prioritize, and integrate information, things coming in sensory, cognitively, emotional, memory, to initiate action, suppress impulses, which people with ADHD have a lot of problems with, and they also have a lot of trouble with shifting attention or shifting behaviors. They get stuck in a rut, is what I like to say. It's responsible for helping you to react and behave appropriately. It controls attention, speech, movement, and emotions like the conductor of a symphony orchestra. Neural networks underlying executive function begin development early, but don't fully develop until you're well into your 20s. Impairments are not always apparent during childhood and may not be seen until you're challenged by the tasks of adolescence or adulthood. We have a lot of external supports with children's sort of external executive function. So here we have the various aspects of executive function: inhibitory control, working memory, cognitive flexibility. These are the core executive functions. More complex ones include problem solving, reasoning, planning, and organization. And these are the areas that adults with ADHD have particular trouble with. It's more important for school success than IQ, interestingly. Predicts math and reading competence, critical for success in career and marriage, and correlated with positive mental and physical health. All of these, of course, can be impaired in adults with ADHD. The prefrontal cortex matures later, as you can see. When you look from left to right, you're going from younger to older. Darker colors are more mature, and you can see here that it takes time for that part of the brain to mature. This is a really important study that was done by Shaw and colleagues, and this shows that there is delayed cortical development beyond what we saw in the previous slide, which is the normal delay, in children with ADHD. And you can see that it's about as much as a 2-year delay compared to age-matched peers in the cortical development of the prefrontal cortex. One of the things that was known before this study was that on average, children with ADHD are 1.5 to 2 years emotionally delayed or less mature emotionally than their age-matched peers. Intellectually, they track right along and may even be superior in some ways. So this really helps us understand some of the pathology as a delay in maturation. So this is gray matter, but there's also white matter deficits that persist into adulthood. Neuroimaging studies do show brain abnormalities. However, they are not valid for ADHD diagnosis at this time. They're not sensitive or specific enough. We can see in various neuroimaging structures abnormalities of structure, globally, but especially frontal, function as far as regulation, modulation, and circuitry, and connectivity with fronto-subcortical networks. Roger talked a little bit about the default mode network and the cognitive executive network that I'll talk about here in a second. This is a prehistoric study, was published in the New England Journal of Medicine in 1990. This is the first published neuroimaging of adults with ADHD, and what you see very clearly is less activity globally on the in a resting state in the adult with ADHD on the right versus on the left. So decreased glucose metabolism both globally and especially frontally, which is to the superior top part of the slide. There's also abnormal neuronal activation in cortical and striatal areas, and what you see here is adults are given an attentional task, and control group without ADHD is activating a very small, they're very efficient. You're activating a very small area of the anterior cingulate cortex. Now look what happens with the adults with ADHD. They're not able to activate, so there's abnormalities of the anterior cingulate cortex, but they can compensate. And this gets to Roger's point of the effort required. Look at the effort that's required. They have to recruit other areas, the frontostriatal insular network, they're recruiting, and you see how much more glucose metabolism and how much less efficient the information processing is. So adults with ADHD can pay attention, they can do tasks, but it takes more effort. And this is why their attention tends to be interest-based. Something has to be really interesting, really worth it, if you will, as opposed to people without ADHD, which is priority-based. This is important, I'm going to pay attention to it. Also, there's dysregulated emotional processing, and this gets to the overlap of mood disorders and ADHD. So what we have on the left, these are children. These are 30 children, 15 unmedicated, 15 with ADHD unmedicated, 15 who don't have ADHD. What you see is the unmedicated, when they're shown a fearful face and then the same face with neutral emotion, the unmedicated kids activate the amygdala. The unmedicated ADHD kids are activating that amygdala, and the controls, what happens is initially when you see the fearful face, you activate the amygdala. So both of them are going to activate the amygdala. It's going to get red hot because that's the fear center. But now this is later when you're shown the same face with neutral emotion, the kids with ADHD can't shut that off. They activate, they're red hot. So they're overly emotionally reactive. Whereas the controls look at it and go, oh, well, there's nothing going on here. I don't need to be afraid. So emotional regulation neurologically, neurobiologically is abnormal here. And again, it's problems with top-down and bottom-up regulation. So we talk about networks of circuit. Roger alluded to this. The default mode network is inwardly focused or self-referential. This is including autobiographical, self-monitoring, social. This is when you're sitting in a room just thinking your own thoughts, so to speak. The central executive network is outwardly focused. It requires higher level cognitive and attentional control and working memory. So let's say you're sitting in a room waiting for a meeting to start. Your default mode network is going. Now the leader of the meeting walks into the room. Well, what should happen is you should shift. The salience network should kick in and shift your focus over, or your network over, to the central executive network so you can pay attention. This is important. I need to pay attention. I need to process this information. And ADHD is disconnectivity, as you can see, and it also supports the theory of delayed neural development in ADHD. And here we have examples of what these networks look like and what parts of the brain are involved. I'll move on because you have copies of these slides. I love this. This is a cartoon from a person with ADHD. How my brain works, I'm either utterly obsessed or uninterested. And I like to say people with ADHD, their brain is all or none, There's very little in between, and they have a lot of trouble with grays and gradients and shifting. What's different about the ADHD brain? The brain is less efficient, as we've seen, literally, process information differently. So how does the non-ADHD brain process information? Well, it processes it by priorities. This is important. I need to pay attention. I've got to do my homework ahead of time. Linear processing, things happen from A, B, C to D. They have a consistent sense of time. We all have some variability of time. If we're doing something really engaging and interesting, it seems like time passes slower rather. But ADHD patients especially have trouble with that. They can delay gratification, most likely because they have intact dopamine networks. They can plan, prioritize, they're proactive sometimes in their thinking. They can learn from the past and anticipate the future, and they can entertain themselves. Well, the ADHD brain works on novelty and interest, as I mentioned, not priorities. It's nonlinear processing. Their brain goes from A to D very quickly. They have a much more variable sense of time. If they're really into something, 5 hours will seem like 5 minutes, and if something is boring to them, 5 minutes seems like 5 hours. They have to get immediate gratification. They're very impulsive, reactive. I like to say they live intensely in the moment, so there's not a good sense of the future or the past, and boredom is your mortal enemy. Common comorbidities, I'm going to skip the child and adolescent for the sake of time and go right to adults. Anxiety and mood, substance abuse, as we've talked about earlier, antisocial behavior. There's many medical comorbidities. Roger alluded to obesity, also diabetes and hypertension. The whole metabolic syndrome is more common in adults with ADHD. They have more insomnia, apnea, and excessive daytime sleepiness, more sexually transmitted diseases due to impulsivity, and more motor vehicle accidents. Sadly, happily, there are a lot of international adult ADHD treatment guidelines, as you see on the slide, including CADRA, the Canadian Attention Deficit Hyperactivity Disorder Resource Alliance, and NICE in the UK. But sadly for us in the US, there are no US adult ADHD treatment guidelines. All right, I'm going to shift into talk about medication. So of course, that means it's back to school time and they're running a special at the pharmacy for Ritalin. So just couple of quick thoughts. The timing here, the scope of my talk doesn't allow for a really in-depth discussion of medication, but I want to give you some concepts here, some thoughts. I like to think about both the pharmacodynamics and the pharmacokinetics of the various medications, particularly the stimulants. So I think of the effect of the drug on the body as pharmacodynamics. What's the mechanism of action of the drug, stimulant versus non-stimulant? If you're talking about stimulants, they fall into two categories, methylphenidates and amphetamines. They both block the reuptake of norepinephrine and dopamine. However, amphetamines, but not methylphenidates, in a dose-related fashion, as you push the dose, they actually flip the dopamine transporter and you pump dopamine out. This is why amphetamines are more abusable. They have much more dopamine kick, they're more potent. And so Adderall, for instance, has a much higher street value than Ritalin, if you will, or amphetamine versus methylphenidate. Non-stimulants, we have atomoxetine. It's the only medication, a non-stimulant medication FDA approved for adults. And that's a norepinephrine reuptake inhibitor versus the extended release alpha-2 agonists, clonidine and guanfacine. We have various non-approved but evidence-based antidepressants, including bupropion, which Roger mentioned earlier. And we have augmentation strategies that I sometimes especially will add an alpha-2 agonist or an SSRI to a stimulant. So those are some of the ways I think through that. As far as pharmacokinetics, this is really critically important for stimulants in particular, because the way stimulants vary besides methylphenidate and amphetamine is in the pharmacokinetics, immediate release, extended release, and so on. So when we think of the effect of the body on the drug, which is ADME, I think of immediate release versus extended release. Excuse me, can somebody mute their microphone there? We've got a little bit of background noise. For adults, I highly recommend, of course, extended release once-a-day preparations, less abusable, less divertible. I think of the duration of action, not dead on arrival. I think of the peak to trough variability, which can affect not only efficacy, but tolerability. There are some that have a food effect, and then I think of drug-drug interactions. Also, we have to take into account patient's preference. Some people may say, I don't want Adderall, or some say, I want Adderall. Well, I might try to work with them to get extended release. Cost, coverage, and access, sadly, is a huge concern in the US in particular. And all of the newer branded stimulants in particular are more costly and difficult to get access to than the generics. We don't have as much time to go into details on this, but I alluded to the mechanism of action of the stimulants is predominantly reuptake blockade, whereas the alpha-2 agonists directly work at the norepinephrine, the alpha-2 norepinephrine receptors, especially in the cortex. There are many FDA-approved stimulants. Believe it or not, there's 29 stimulant preparations approved, only 6 approved for adults. All are XR, and that's methylphenidate oros, which is Concerta, D-methylphenidate XR, Focalin XR in the US, methylphenidate multi-layer release XR, This is actually available in Canada. I believe it's called Trifentin or Foquest, perhaps. And then Bifentin is the earlier version. In the US, we call it Adhancia XR, Lisdexamphetamine Vyvanse, mixed amphetamine salts XR. We have Adderall XR, and we have Mideas, which is actually a triple B. And then we have 5 types of stimulant chemical compounds. So not only methylphenidate, but that's the racemic mixture. We have dimethylphenidate, we have racemic amphetamine, we have D-amphetamine, and we have mixed amphetamine salts. These are some of the different type options of medication that you can fine-tune for your adults with ADHD. I don't have time to go into all the details, but you can see there's many methylphenidate preparations, including liquids, chewables, oral-dissolving tablets, patches. Here are some of the others. Sorry, please make sure you mute yourself. I can hear a lot of background noise. Thank you so much. Amphetamine options. We also have lots of different amphetamine options, both duration and the preparation, the formulation as far as how it's ingested. Again, we have liquids, we have oral dissolving tablets, we have chewables. We don't have a patch yet. As a matter of fact, there is a patch in development, an amphetamine patch in development. Here's some of the other stimulant formulations in development. There's actively research on more stimulants. So we have 2 preparations. One is dimethylphenidate XR, one is D-amphetamine XR using unique proprietary extended release technologies. They're designed for early release with all-day duration and a smoother off, not a crash or rebound on the back end. There's a methylphenidate prodrug, which would be the demethylphenidate version of Lisdexamphetamine, which is an amphetamine prodrug. There's racemic amphetamine XR, which is 50% D and 50% L. Adderall or mixed amphetamine salts is actually 3/4 D and 1/4 L. And I like to say some patients need more L. So this is the racemic 50-50 mixture. The problem with stimulants, we have a number of problems, including tolerability and safety. So you can see all the side effects listed here, particularly insomnia. Decreased appetite and weight loss is usually not a problem. It's a desirable thing sometimes in adults. Safety, we see cardiovascular, the risk of mania and psychosis, abuse, misuse, and diversion, and vasoconstriction warning that was relatively recently added to all stimulant medications. What about ASD? Well, Mrs. Stevens, your son is exhibiting classic symptoms of attention surplus disorder, or ASD. We think that with the right medication, he could begin to fit in with the rest of his classmates. So this just reminds me, of course, to be careful with my diagnosis and my prescribing of medication. How about non-stimulants? As I mentioned, atomoxetine is the only one that's approved for not only children, but adults of the non-stimulants. We have, for children and adolescents only, the extended release guanfacine and extended release clonidine. There are a number of studies now using these in adults, and they have been shown to be effective. What's nice for them in adults is you kill 2 birds with 1 stone, because you can also treat their hypertension. Tends to be a little constipation in my experience with adults, however. Then off-label, we have bupropion. There's some tricyclics, and then the wakefulness-promoting agents, modafinil and armodafinil. There's a couple of other newer wakefulness-promoting agents that are on the market. Suvorexant is one, and I'm blanking on the name of the other one, that are approved for excessive daytime sleepiness. They probably also off-label would be effective here. And then non-stimulants in development. Well, disotrolene, sadly, development recently stopped due to some tolerability, side effect, and risk issues. Centanafidine just reported out positive data in adults with ADHD, and is probably about a year away from approval in the United States. Viloxazine XR, very germane to our discussion of the overlap with ADHD and mood disorders. Viloxazine was regulatory approved as an antidepressant for many years in Europe, and then Supernus, a company in the US, in-licensed it. It was immediate release and a 3 times a day drug in Europe. They made an extended release version, and they're actually getting it approved for ADHD in adults and children. They are going for the child indication. As a matter of fact, in the US, their PDUFA date, which is the date the FDA will decide if they're going to approve it or not, is November 8th. So it's coming up for children and adolescents. They have adult trials ongoing, so I expect that it probably will be effective in adults and get approved for that in a year or 2. The mechanism of action is unique, and this is the drug I mentioned that has some serotonergic component. It has norepinephrine reuptake inhibition, and it has actions at 2 serotonin receptors. It's an antagonist at 5-HT2B. Now, what's interesting there is we've recently learned about 2B. that 5-HT2B receptors are on GABA interneurons in the raphe nucleus where serotonin cell bodies live. If you block 5-HT2B, you actually end up inhibiting the action of the GABA interneurons. So you don't have GABA means you don't inhibit the serotonin neurons, so you're disinhibiting them and you release more serotonin up into higher parts of the brain. Also, it's a 5-HT2C agonist, which is interesting because that may decrease appetite actually, but also have beneficial effects for mood and attention. So this is a very unique mechanism of a mixed modal mechanism of reuptake inhibition into serotonin receptors. We have Mazindol, which is a non-stimulant of unique, may work through the orexin system. We have some H3 antagonists, which increase histamine. There's an AMPA modulator. There's a 5-HT1A, 1B partial agonist. There's a norepinephrine dopamine reuptake inhibitor. And there are digital, such as therapeutic video games. A game from a company called Achille. The Endeavor game was recently cleared by the FDA in the US. It sort of trains the brain. And then there is some preliminary data on TMS. One quick thing as we round the corner here towards the end is the issue of abuse and diversion. Can you spare some Adderall? I want to dispel a little bit of the myth here. The majority of the use, for instance, illicit stimulant use or misuse, is for helping me concentrate and helping me study on the left of this slide, and then increasing my alertness. And I just wonder how many of these are self-medicating ADHD patients, but you can see giving me a high is a little down on the list. Certainly, I don't want to minimize it's a real problem, experimentation, and then even helping me lose weight. But I just want to emphasize that probably some of these people are undiagnosed and they're self-medicating, or they were diagnosed, but they can't get access to medication. So just a caution on being too hysterical about everybody trying to game us and abuse stimulants. As far as non-pharmacologic interventions, education is critically important. I always recommend websites such as the CHAD website, the Adult ADHD Association. Cognitive behavioral therapy is very important. Using devices, electronic devices is very important. The advent of smartphones has been a boon to adults with ADHD. And then individually, self-esteem issues, social skills and relationship issues. There's coaching. ADHD coaches are very effective. There's also people who specifically specialize in, or they're organizational coaches who specialize in ADHD, academic and occupation accommodations and electronic devices. Well, I think that's it. I don't always have ADHD, but penguins are my favorite color.